And we're back. If you were joining us just a few minutes ago with the LinkedIn Live presentation of healthcare quality and risk matters, we are shared. Our show has been shared with our new guest for this month, Monica Dowling. We're talking about long-term care. As usual, this is the first time you're joining us with the after show. My name is Gary Bierce. I'm the CEO of Aperitisoft Healthcare, joined by our Chief Operating Officer, Rob Sandamore, and our Head of Customer Success, Dr. Timothy Brown. We talk about everything healthcare quality and risk here at the after show, and we go ahead and pull up all the restraints and everything that would keep us from talking plainly about the topic. We had a very good show, Monica. Thank you so much for joining us in the live broadcast. Maybe we should start off by asking you a question. What are you willing to tell us that you were not willing to tell us in mixed company about quality, risk, working with the Aperitisoft healthcare system? We'll let you begin the conversation.
Okay, well, that was kind of a surprise question because there really isn't much that I wasn't willing to talk about in the other podcast.
Good.
We appreciate that. Yeah.
So,
Good.
I mean, I tried to
How
share
about a
with
frustration about long-term care? Let's go there.
Okay.
Let's talk about the long-term care industry and what are some of the great frustrations and challenges that you're up against that bleed into the quality and risk area of running your business.
Okay. Well, one thing I'd say in long-term care, it's not as there's very little automation, and I'm trying to automate different pieces as we go, trying to go along. It's a journey, right? Automation and becoming digital is a journey, whether it be document control, good sound EMRs and processes around that, tools like Aperitisoft that are risk management, compliance management, corrective action planning management. All in all, in long-term care, there's a lot less focus on quality and risk management, and there are a lot of issues in a lot of facilities.
I mean, I'll throw one out at you. A former board member of my company, still a dear friend. His mom is in an assisted living facility, and his mom fell out of a chair, and she laid on the floor. She can't get up. She was there for 15 hours before somebody finally identified her.
No.
Of course, she went to the bathroom in her pants. She had all kind of enormous things that went wrong. She had medication she was supposed to take during that time period. None of it was taken while she laid there screaming for somebody to help.
Can I ask a question to that point, Gary and Monica, being a leader of the long-term care facility? How does that happen? How does a patient fall and then there's no one that views them, checks in on them for 10 to 15 hours? I mean, hypothetically, because we're going to knock on wood, this doesn't happen.
How could it possibly happen? How could it even possibly happen?
How is that even possible?
Well, it wouldn't happen in my facility, but
yeah, exactly.
I've heard of ones close to me where it's been at least 12 hours where a person actually died overnight, and they could tell.
Oh my goodness!
Jesus.
They could tell time of death was 10, 12 hours ago, and nobody ever really checked on the person.
That's outrageous. That is unbelievable.
Now we do rounds at night. We do rounds every 2 hours, but if nobody actually went and checked on the person, they could have fallen at night if they didn't have, like we talked about, a lot of restraints or alert systems. Like we have bed rails, we have bed alarms, we have screamer alarms on the person if they're really high risk. We have fall mats. We have call buttons around their neck that they wear if they're able to use those devices. And then we do checks every 2 hours to go around. So somebody, if they fell, if they were a person who was a high fall risk,
she is, by the way.
Have the alarms going off.
This person's mother is a high fall risk.
Right. So we would have had
no
alarm
dementia,
going off on the
dementia
bed.
whatsoever.
Right. That we would have had alarms on the bed that would have gone off, let alone doing the rounds every 2 hours. But we would have heard the alarm screaming out of the room, or if the person hit the call button that they were wearing, if they were aware enough to do that. But if they had dementia and weren't, we would still have the alarms going, whether it be an alarm tied to their body when they get up that pulls and it pulls a string and it goes off, or when you get out of a bed alarm, basically when somebody gets off of it, it goes off. All right. So if somebody goes off, so we would have had alerts and so forth, but those can be very serious matters. Then you have the Agency for Healthcare or police even coming in wondering what on earth's going on, that depending on circumstance, that person may not have been on hospice. It could be a surprise death that they fell and then they had a brain bleed or they broke a hip or whatever it is, and laying for that amount of time for 15 hours, it could go from a fall where we could have sent them out, gotten treated, taken care of, to now it snowballs. If they didn't come out for breakfast and didn't get their morning meds yet or anything, they may have blood pressure issues. It can snowball when somebody's left on the floor.
Just how quickly that does snowball, right? You go from there's a patient choice that you could document as a patient choice. You had everything in place that you could have possibly done to prevent it, to patient choice to fall, all the way to negligent and potentially criminal action. Nurses are going to jail. There's for things like this. I don't know how organizations, how healthcare facilities don't put a focus on the controls around things like that, right? How do we make sure these things don't happen? Because honestly, Monica, you're a front runner, not many. I would say most do not.
Yeah, I would say you're a leader in your industry.
Correct.
And how you're approaching things, taking it serious, wanting to have automation. It's astounding, and you're seeing the results though, right? You're seeing that it makes a difference. And this individual though, his mother doesn't want to leave, right? She likes her place, and I guess you run into that a lot, Monica, when people reach that age of their life, they don't want another change.
Right. It's hard. Change is very hard, and it's hard for them to adapt. But the family is usually the ones pushing for some change because they're unhappy.
They are, but she refuses. So they're reporting the facility to the Department of Health. They're doing all the things that they can do, but I just can't even imagine how that can happen. Is it a staffing problem? Is it a management problem? What is it? I mean,
it's both. It's both. It's that and processes. It's probably not having processes in place to safeguard against it, right? The type of things and preventative measures that could be taken, as well as having process of, I don't know if they have a process to do rounds every 2 hours or whatever. The other is monitoring the staff. Are the staff sleeping at night? Most likely 12 of these hours were at night, right? So are they sleeping at night instead of doing their rounds or not following the processes? So it's really all of it. And it probably isn't the first time something happened.
It wasn't. They've had all kind of medical, not giving medication, pharmaceutical issues. It's obviously there is a string of incidents that are happening in this facility that are going unchecked and uncorrected. I think this is like they're on the third executive director in 2 years.
That's something right there.
Yep, the churn. Yep.
Depending on they're having a turnover of nurses, turnover of staff, turnover of leadership, and when that happens, there's no continuity of process, and things don't get done.
That's where it's probably going back to lack of documenting processes as well. If processes are documented, then it shouldn't be as big a change, even if you change the director or whatever. It should be, here's still our processes that we follow.
That's correct. I'm baffled. I don't know about anyone else, but to have a patient laying on the floor for 10 to 12 hours, that is just, I don't know. It gets under my skin a little bit, from a healthcare administrator standpoint. It just how does that happen? How do we neglect our patients that often, that long?
My father-in-law went into rehab after having a heart attack, and we were dealing with those kinds of nursing facilities, higher nursing facilities, and it was insane. I mean, I couldn't believe it, the negligence that existed.
That's why I said you can pick the areas. I think you said he had bed sores or whatever, right? And that goes under one of my risk categories of skin integrity, right? Whether it's bed sores, skin tears, so forth.
His
You gotta have early
bad,
alerts.
Monica. It looked like he had 2 bullet holes
Jesus.
on his lower back, or down there, the above the rump, but in the lower back down there. They were that deep. They were probably 3/4 of an inch deep, both sides. They
And then it gets very close to like getting through right into the spine. That it's just skin there, and not much in between that, and being able to just see into the spine. So
and that was the first 2 facilities we had him in. One started it, the second one it continued, and we got to a 3rd facility, and then it started to change.
Right. And these type of things can be prevented, and if not taken care of, they can cause death. Whether it be falls, it be skin integrity, bed sore particularly,
infections,
medication issues. That's why I said when I went through and I looked at the type of incidents we had, we grouped them in 3, and then we worked on brainstorming of corrective actions, improvements we could make in each category to stop this. Because if you're talking about bed sores, you can basically put a rotation log in that room, and you just make sure the person stays off their backside. Every 2 hours during the night, they go side to side. You have pillows around them. They don't lay on their back. A lot of places, they just let them lay on their back, watch TV all day, all day long, all night long, and they're laying on the same spot. And what do you think happens? And they're incontinent on top of that. You may put a catheter in the person too, if that's another issue that could help as well. But you have to assess to see what do you do to prevent these type of injuries that are preventable, but otherwise they could actually be the cause of death. So the person may have a heart condition, they may have cancer, but they're going to die from infection and a bed sore.
Yeah, it's sad.
Hey, Monica, how do you mitigate the staffing shortages? Because I know that when we're looking at long-term care facilities, that really is a major issue. I was looking at one stat that said around 87% of long-term care facilities are reporting a moderate to high level of understaffing. How do you mitigate those overall issues for your organization?
I laughed because that was about to be my question.
Well, we've had, I think, about 2 positions that we had some issue with rotating. The rest of them have been pretty stable.
Okay.
That's not normal for your industry, though. You should acknowledge that you are way above average, that your organization is highly functioning.
Do you think it's because of your proactiveness with healthcare quality and risk management, providing that crisis-free environment most of the time? I know in healthcare you can't ever promise to be crisis-free, but to have minimal crises, you think that plays into it? That people they enjoy their work more, and they enjoy coming to work and working with the residents there at your facility, rather than having a fire drill every time they come to work.
Yeah, I think they realize that we put the safety and well-being of the residents very, very high up, and we take really great care of our residents. And that's what's expected if you work at Bayshore, nothing less.
It's interesting. My niece is a nurse, and she I think she's 2 or 3 years in now, Rob. I think we've talked about her before. She's the one in Bond Secures. And she works in the neonatal care area. Now, she loves her job, and she says there's very little turnover in her unit there.
The little
very specialized.
Yeah.
Very, very specialized. And these nurses, everything are these children. Everything. I mean, they to the point where they group together with certain kids that don't have parents to support them, or they have special needs. They'll work together to become the foster parents for these children. They're that devoted. It's quite an amazing thing. And she basically says, well, they don't have any slots open. They haven't had them since she was hired because nobody wants to leave.
Mm-hmm.
You know,
And
it's
speaks to culture.
It does speak to culture, and I do. So there is a wide range of nursing specialties, and unfortunately, long-term care tends to pay lower than other nursing specialties. Not universally, but there's statistically they do pay lower. And that adds to the challenge and of recruiting people for that specialty. Just like the neonates, the geriatric, there's dying population, right? Your end of life people who are palliative or hospice. Those are there's intricate specialties that take a lot of thought, a lot of experience, a lot of practice. And as a industry, we don't pay them well. We have to recruit them through quality.
Mm-hmm.
You can't recruit through pay. The reimbursements aren't high enough from our payers, and whether that be government or private. And Monica, if I'm wrong in any of this, please correct me.
Mm-hmm.
And so we have to recruit for quality. And I, as a nurse, love chaos. I was an ICU nurse. There's a transplant nurse. I lived in chaos, but my chaos was organized. It was intelligent. It was methodical. No matter what went wrong, I had a process to control it. And that is what organizations like yours, Monica, now do. Unfortunately, your counterparts are not doing that. So people are nervous about going into those specialties knowing that it's disorganized chaos. And I, as a nurse, will not put my license at risk in disorganized chaos. I'm not doing it.
Mm-hmm.
It's too hard to get it back once it's gone. Most likely it's gone forever. And my entire livelihood is based on those initials. And so I'm not going to sacrifice it by going somewhere that I know is not putting the patients first, therefore not putting me first either.
That's good.
So your challenges in your industry are very, very high when it comes to those things. So quality is paramount to recruit people and maintain them.
Yep.
That's good.
Yeah, I think if you don't have quality, I mean, it prevails throughout in everything. That's why I said it's whether it's the staff, getting quality staff, they're not going to want to go to a facility that's poorly rated. You're going to have a lot harder time hiring staff if you have a poor rating, and people who are coming in to interview can check that out, right? So they won't even apply to begin with. So that would be, a first hurdle, right? So let alone families and getting patients or residents, right? If you have a poorly rated facility, poor quality, have had a lot of issues. A lot of the surveys are very public. So we have our latest, ACA surveys are public information, right? So if they can read, here's your last survey and here are all the issues that came up from your last survey and, what have you done about it? That would be a major obstacle to getting in new patients or residents in a facility.
Yeah.
So having high quality and a good quality compliance program is very important to actually having a good business. Right? If you look at it as a business, it still has to run. The hospital has to run. The long-term care facility or group of hospitals or care facilities has to be able to manage, and it all links together, right?
And Monica, you speak about that so smart and so plainly, like it's just second nature. Like everybody knows this. It's so logical, right? So how come none of your colleagues in the long-term care space doing the same job that you have are able to put those pieces of the puzzle together? Why aren't
I think it hasn't matured. Yeah, it hasn't matured to the level it has at hospitals. Hospitals have very public ratings, whether it's the Leapfrog rating, CMS ratings. They're very consistent and across the board. You don't have anything like that at this point in time for long-term care. There's no rating system that shows one versus the other. You can have, like we've had from Senior Advisor from A Place for Mom, we've had a 5-star rating from them based on our reviews from family members of residents. That's pretty much how you get those ratings. But there's not a government rating system, right, of
Right.
long-term care. So there is not
Or an
the same
independent
consistency.
independent body. That's
There's no
around it.
independent body or whatever. Even the government, they don't give you a rating. Like CMS will give hospitals a rating. They don't give long-term care a rating when they come in and do their reviews. You'll get your biannual renewal. If they come in for a complaint, that'll be addressed individually. But at this point, we don't have something like that. So when families are trying to go around, it's a struggle for them to find a place, and they often. I have one lady with me. We are her 9th facility that she's in.
Jeez.
Oh my goodness.
So she's still with
Wow.
us, but it's her 9th facility that her mom's in. So that'll tell you something that.
What?
Yep. So
that speaks to the industry.
it does,
And-
because
and
it's
and
like
how poor it
I'm
is.
just saying.
Yeah.
It's why is she still with us? Because we take great care of her mom. That's why
Why
she's still
why
with us.
aren't CEOs, executive directors of these facilities looking to improve, to do what you did? Why are they not taking the same types of steps, or even seeking them
question.
out? It's very interesting to me.
Mhm.
Or are they? We just don't know.
What
I mean,
Becky?
there are not a lot of tools that have been accessible for long-term care. I mean, Aperitisoft Healthcare with what's being offered as a very easy system to get going, load into your facility,
Mhm.
get started. I mean, it takes a few weeks to get started. We chose to start with the incident management module to just get all our incidents in there as they come, and then work on corrective action plans and get that all in there. And it's a very integrated system, and helps you from a risk management, an audit standpoint, a document control standpoint.
You got
But there
all
aren't
your
a lot of
procedures up on the dock control as
right.
well. right
There
now.
aren't a lot of systems that I've seen out there in long-term care to help us manage this. It also has not been the biggest push. It's more that they have struggled, and with COVID, it was even a bigger struggle just to survive, just to like be able to staff and not. It's just almost like a downward spiral in a lot of places. It's like constant chaos, so you can never get out of it.
That's interesting.
That's an interesting point, Rob, what she's saying there. It's constant chaos. I can't get out of it.
Yeah, do you see, I
Absolutely.
reacted.
That
I
is
think all three of us reacted really highly to that comment.
Yeah.
There's so I understand that to an extent, right? I have walked into facilities as both a consultant and a risk manager. And honestly kind of spun in a circle, like, where do I start?
Mhm.
It's not easy. To figure out what that starting point is. But I do feel like you've already designed the recipe for your colleagues. You identify the risks, right?
Start there.
Let's
Mhm.
start figuring out where my problems are. You said it
Great
very
issues.
well in there's live podcast. I hope this message then continues on to all those same people to say, just figure out what's going on. Just get a baseline. And get all of the eyes, so you have the line of sight, everybody documenting everything you see. Let's collect the data. Now you can start tackling those things.
It's kind of like you just got to start.
You gotta start somewhere. Yeah.
Right. Just
Well,
gotta
we just started. We just started doing incidents. First of December. You start. Okay, let's just log all our incidents
It's a
that
big
come in, and then
hospital,
we.
though, say it's a big hospital.
Yep.
And they're like, I've got 25, 30 departments here. Where do I begin? Well, you said it in the live broadcast. Which ones are having the biggest problems?
Yep.
Mhm.
Start there.
You could
Right.
look at your last survey report that came, right? You might have a 100-page survey that came in, and you got to go through, whether it's for one hospital or the whole network or what it is, and go through and understand what happened, and rank them, put them in each of the, incidents or groups of incidents you can put together, and then start evaluating and prioritizing where you're going to focus your effort based on the biggest risks.
That is very wonderful advice.
It is.
And I would love to find a way to communicate. And yes, I want them to use Aperitisoft Healthcare, but ultimately we all have the same mission. We want healthcare to be better. And then, so like just start identifying. We will help you do that. And here's your problem area. We'll help you start fixing it.
But our frustration, Rob, has always been the resistance to change.
Now I know there's like
Absolutely.
they're stuck in chaos, but they're
Monica, she's done it. Right? It's a
staying.
no-brainer to her. My gosh, it was easy. Getting people to realize, look, you can make a paramount change to your organization in this area. And all of a sudden you are funding projects because you have money available.
Correct.
Right? You can do things.
I can't even imagine. That would be amazing. Just right. Like
it all begins by taking a step to do the right thing. And the problem, let's talk about it fairly here. The other systems that are out there were not designed for this.
No, they were designed for automotive industry or the oil industry or Walmart.
They're not really designed to do the way that we are doing it at Aperitisoft Healthcare.
Healthcare doesn't have the same.
It should be a no-brainer. It should be a no-brainer to management to make this step to correct things, to make things right. And I know we're dedicated as a team. We're going to keep knocking on doors and telling people what we have going, and to get people to realize that they can have the benefits that Monica has experienced in her facility.
It was very easy to just get it set up, get it launched, and start using it in a few weeks. Not like months or years to get going.
Years, yeah, right.
And you have no additional administrative resources. Your overhead, your administrative overhead in your organization is very small. All of you wear a lot of hats.
Yep.
And all of you were able to do it. Because I know that's an argument, right? We don't have the administrative capacity for that level of change. You have, I would say, negative 10% capacity. All of you are working well over max capacity, right?
And you don't need to be.
Right. And you are still able to implement effective and positive change. And you have the data to prove positive change. You are saving your patients, and you can actually see yourself doing that.
And it prevails throughout everything, whether it's the revenue side, the cost side, the legal risk side, and in morale and just work-life balance, everything in the whole facility, just getting a handle on where your risks are and having a sound quality program, and your reputation in your community, right?
Yeah.
One last question for you, Monica. How Aperitisoft Healthcare, we do business differently. We're not dropping software in your lap and saying, here's a couple of training modules, go through your training modules. If you have any questions, call this hotline to somebody in India who's going to, be able to help you with whatever your issues are. We literally hold your hand, help you with training, help you get set up, help you to make each of the steps along the way. How helpful was that, and how unusual was that to have a company work with you at that level?
Well, it was like you have like a consultant from the company there to help you get going, to make sure you actually get it up and running. That's part of what we do. It's not something outside of what we do. It's what we do to help you get up and going.
And hold your hand all the way through the process.
We all want this to be a success, right? To help your organization, to help improve the industry. That's kind of my ultimate goal as far as trying to help others now and share some of what I learned and what we can do to improve in the long-term care industry. What can we do to move the needle forward with our organizations, and helping each other out as executive directors or administrators of facilities, and sharing the knowledge and these tools that are available to us. Any
last questions, guys, or last words for Monica?
No, this has been amazing, Monica. We appreciate you, and happy long-term care heritage to you and your organization.
All right. Thank you, everybody.
Thank you.
Thank you for sharing with us. And hey, if this is the first time you're checking us out on YouTube, thank you. And please let your friends know about it. We hope we're going to be a resource for you for many, many years to come.